Hello students, myself Maheswaran, Assistant Professor from Renal Dialysis Technology Department from School of Allied Health Science. So today's we are going to see on the topic nephrotic syndrome. So nephrotic syndrome, first initially normal anatomy of kidney and nephron, let me see into it. So kidney we do have outer cortex and inner medullary region. So nephrotic syndrome occurs into the glomerular region of our kidneys. So we do have around 3 million nephrons in both kidneys. So glomerular damage causes your nephrotic syndrome, which leads to proteinuria around 3.5 grams per day. So glomerulonephritis. So glomerulonephritis is a term used for disease that primarily involves our renal glomeruli. So glomerular diseases are classified into two broad groups. So one is primary glomerulonephritis. In primary glomerulonephritis, which glomeruli are the predominant site of involvement of nephritis. In secondary glomerular disease, which includes certain systemic and hereditary diseases which secondarily affects our glomeruli. So clinicopathologic classification of glomerular diseases. So primary, secondary and hereditary nephritis. So primary glomerulonephritis, so acute glomerulonephritis, which includes post-streptococcal, non-streptococcal, then rapidly progressive glomerulonephritis, minimal change disease, membranous glomerulonephritis, membranoproliferative glomerulonephritis, focal and diffuse proliferative glomerulonephritis, focal segmental glomerulosclerosis, IgA nephropathy, then chronic glomerulonephritis. In secondary systemic glomerular diseases, we do have lupus nephritis, diabetic nephropathy, amyloidosis, polyarteritis nodosa, vaginous granulomatosis, Goodpasture's syndrome, Hinox-Conlin purpura, then systemic infectious diseases which includes bacterial, example bacterial endocarditis such as syphilis, leprosy, viral, example hepatitis B virus, hepatitis C virus and human immunodeficiency virus which is HIV, parasitic, example falciparum malariae and filariasis. So idiopathic mixed cryoglobulinemia. Then coming on to the hereditary nephritis, which includes Alport syndrome, Fabry's disease, then our Neil-Patella syndrome. So what is nephrotic syndrome? So nephrotic syndrome is a pathognomonic of glomerular disease. It is characterized by heavy proteinuria more than 3 grams per day, hypoalbuminemia, edematic conditions, then hyperlipidemic conditions, lipiduria and hypercoagulability. So coming on to the etiological causes, so nephrotic syndrome can be of primary or secondary causes. So primary being a disease specific to our kidneys, which is glomerular involvement is a predominant site of primary causes. Secondary being a renal manifestation from systemic diseases, that is systemic diseases includes in secondary disease conditions. So primary causes which includes our minimal change disease condition, 70 to 90% in children, which occurs most commonly, then membranous nephropathy 30% in adult conditions. So focal segmental glomerulosclerosis, which is a type of primary causes, then membranoproliferative glomerulonephritis, MPGN type 1 and MPGN type 2, rapidly progressive glomerulonephritis, which is RPGN, it is mentioned with crescentic glomerulonephritis. So secondary causes of glomerulonephritis which includes diabetic nephropathy, then amyloidosis deposition, that is amyloid protein deposition, then lupus nephritis, systemic lupus erythematosus, then viral infections which includes hepatitis B, hepatitis C, then human immunodeficiency virus. Proteinuria. So presence of protein in urine is said to be as proteinuric conditions. So normal glomerular capillary which appears normal with red blood cells, protein and urine. When a capillary with proteinuria appears, proteinuric leakage over there. So heavy proteinuria, protein loss of more than 3 grams per day is considered as proteinuric condition. It is the chief characteristics of our nephrotic syndrome. So increased glomerular permeability or any damage in glomerular basement membrane or in podocytes, it may cause proteinuric conditions. So in nephrotic syndrome, proteinuria mostly consists of loss of albumin in the urine. So hypoalbuminemia. As we seen that proteinuria includes loss of albumin, it prolongs to albuminuric conditions. So decreased level of albumin in blood is known as hypoalbuminemic conditions. Hypoalbuminemia is produced primarily consequent to urinary loss of albumin and partly due to increased renal catabolism and inadequate hepatic synthesis of albumin. So edematous condition. So next to hypoalbuminemic condition, edema occurs. So edema in nephrotic syndrome appears due to fall in colloidal osmotic pressure consequent upon hypoalbuminemia. The consequent decrease in circulating blood volume produces a secondary stimulation of renin-angiotensin system resulting in aldosterone-induced sodium and water retention, further contributing to edematous condition. So pathogenesis of edematous condition, primarily proteinuria will occur, followed by that reduced albumin level in body. Next to that, oncotic pressure will get decreased, due to that edema occurs, then reduced blood volume, which consequently increases the production of renin-angiotensin system. Hyperlipidemic condition, increased lipid profile in blood. Hyperlipidemia is such a frequent finding in patients with heavy proteinuria that it is regarded as an integral feature of nephrotic syndrome. It is hypothesized that the liver, faced with the stress of massive protein synthesis in response to heavy urinary protein loss, also causes increased synthesis of lipoproteins. There are increased blood level of total lipids, cholesterol and triglycerides, VLDL and LDL cholesterol levels. So lipiduria. So lipiduria occurs following hyperlipidemic condition due to excessive leakiness of glomerular filtration barrier. So lipiduria is manifested by the presence of refractile accumulations of lipid in cellular debris and cast, oval fat bodies and fatty cast. So lipiduria will present with like this. So fatty cast, and this is oval fatty bodies. Patients with nephrotic syndrome may develop spontaneous arterial and venous thrombosis, renal vein thrombosis and pulmonary embolism due to various factors includes. This includes increased urinary loss of antithrombin 3. So antithrombin 3 is a factor which helps in clotting. So hyperfibrinogenemia from increased synthesis in the liver, increased platelet aggregation and altered level of protein S and C. Signs and symptoms of proteinuric patients. An early sign of nephrotic syndrome is presence of foamy urine, presence of edema usually in peripheral puffiness in face and eyelids drooping were seen in children most commonly. White bands in the nails, which is known as Muir lines, are a characteristic clinical sign of hypoalbuminemic conditions. Clinical stigmata of hyperlipidemia such as xanthelasmas, anorexia, malaise, abdominal pain and wasting of muscle will be seen in nephrotic syndrome patients. So white bands in nail due to hypoalbuminemia, which is known as Muir lines. So xanthelasmas, accumulation of this cholesterol deposits over the eyelids is known as xanthelasmas condition. It develops due to hyperlipidemic conditions. So diagnosis. So urinalysis is the predominant thing which is helpful in nephrotic syndrome analysis. So heavy proteinuria usually without microscopic hematuria. Urinary microscopy will show hyaline cast as well as sometimes lipid cast will be seen. Urinary protein measurement 24 hours, nephrotic range of proteinuria more than 3.5 grams per day in adults or 1 gram per meter square per 24 hours in children. Serum albumin hypoalbuminemia conditions lesser than 2.5 grams per deciliters. Serum lipid profile will be hyperlipidemic. Serology studies for infection and immune abnormalities can be done. Renal ultrasonography helps in diagnosis, then renal biopsy which confirms the diagnosis. So treatment for nephrotic syndrome patients. So immunosuppressive drugs like corticosteroids such as prednisolone are generally effective in minimal change disease conditions in children. 60 mg per meter square per day is usually given for 6 weeks. Treatment should be stopped over 6-week period once remission is noted. For frequent replacing, second-line therapy, cyclophosphamide and chlorambucil and cyclosporine can be used. So next on treatment will specify on AC inhibitors. So angiotensin converting enzyme inhibitors or angiotensin receptor blockers are used. It may reduce proteinuria, so hemodynamically either by blocking efferent arteriolar constriction or by reducing preglomerular pressure. Edematous condition. In edematous condition, patient can be given with diuretics like loop diuretics. Example, furosemide spironolactone, which is a potassium sparing diuretics, will be used. Moderate sodium restriction should be undergone by edematous patients. Then hyperlipidemic condition. In young adults, statin therapy should be considered if the patient has a significant comorbidity. Example, coronary disease, diabetes mellitus, then stroke conditions. Dietary restriction of lipids. Hypercoagulability. So anticoagulation is need to prevent thromboembolic complications. Example, heparin, low molecular weight heparin, then warfarin. Correction of hypoalbuminemia. Adequate dietary protein supplement has to be taken by the patient. It should be ensured that 0.8 to 1 gram per kg per day has to be taken with a high carbohydrate intake to maximize use of that protein. In patients with a heavy proteinuria, the amount of urinary protein loss should be added to dietary protein intake. So avoidance of nephrotoxic drugs such as radiocontrast agents, then cytotoxic drugs, then antibiotics, example aminoglycoside antibiotics, which can be nephrotoxic to the kidneys. Should also be used with caution in patients with glomerular disease and renal impairment or nephrotic syndrome. Thank you all students.